But the time-varying effective reproductive number, RT, is data-driven. So the example on the slide illustrates how we estimate this quantity. We can think about RT as the ratio of the number of new infections to the number of infectors in the population at a particular point in time. So if we were omniscient, if we could observe every single transmission event, we could just look into the population on a given day, and we could count the number of infectors and the number of infectees. We could take the ratio, and we would get an RT estimate directly from those observations. But of course, we can't actually observe every transmission event as it's occurring in real time. And so in order to do this using data that we actually can observe, we have to do a little bit of math. And this equation might look intimidating, but I promise that it is actually fairly easy to understand. So the equation that we use allows us to translate data that's really easy to observe on the counts of the number of new hospitalizations or cases or deaths that's occurring at a particular point in time. And so it generalizes that idea that we need to think about the numerator, which contains the total number of new infections, and the denominator, which tells us the number of infectors that are in the population right now. So let's start with the numerator, which is pretty easy to understand. The numerator is something that we call I sub t. It just represents a count of the number of new transmission events or the new infections that are occurring today on day t. And so this is a number that we can look up in a data table and read directly from the observed counts. Next, let's talk about the denominator, counting up the number of infectors that are present in the population at a particular point in time. So here, the math looks a little bit more complicated, but really what it's saying is that we need to look in the population at the number of individuals who became infected at recent time points in the past, because those are the people who have now progressed far enough through their course of infection that they're shedding the virus and causing new transmission events today. So that I of t minus s in the numerator, or rather the denominator, is a count of the number of new infections that occurred s days prior to the current time point. So if s is 1, it's telling us the number of new infections that occurred yesterday. If s is 2, it's telling us the number of new infections that occurred 2 days ago, and so on and so forth. So again, that's just something that we can look into a data table and pull out of the observations, and we can look back at all previous time points in the epidemic to figure out how many new infectors there might be. And then the last step is that we have to weight the current contribution of those individuals to transmission today using something called the generation interval distribution. So the generation interval distribution is defined as the distribution of waiting times between the moment that individual 1 and individual 2 in a linked chain of transmission become infected. So this is something, again, that we can estimate from data, which might come from contact tracing or line list data. And we can plug that estimate in, and it tells us how infectious someone who became infected themselves 1 or 2 or 3 days ago is right now. And so we take the number of individuals that showed up in the data in the recent past, we scale their current infectiousness using the generation interval, and we look back across all possible days in the past that people might have become infected, and we sum them up, and that gives us the denominator, the total number of infectors that are currently actively causing transmission today. And so if you take anything away from this slide, really what this is illustrating is that we can estimate RT using very simple data. The only ingredients we need to do this are counts of the number of new infections occurring each day and an estimate of the generation interval distribution. And whether or not you followed the math in detail, you can take away the idea that really what we're doing here is we're using the data that we can observe to estimate that ratio between the number of new infections and infectors that are occurring at a particular point in time. And I think the beauty of this approach is that it takes into account implicitly the level of interventions or behavioral changes that are going on right now. So we don't necessarily have to measure those things directly or quantify their effects. They're represented implicitly in the level of transmission that we can observe based on changes in the number of new events in the epidemiological data. So now that we have a better understanding of what the time-varying effective reproductive number is, let's talk about how we can use it in public health practice to support decisions about outbreak response. So this is an example of estimating RT using data on the number of confirmed cases that were observed in Wuhan very early in the COVID-19 pandemic. And I'm actually presenting this particular figure as sort of a cautionary tale to illustrate how careful we have to be in producing these estimates to be sure that they're accurate, correctly oriented in time, and accurately representing all sources of uncertainty. So the golden rule in quantitative epidemiology is that when RT is above 1, the epidemic is growing. On average, each new infection is more than replacing itself. And when RT falls below 1, the epidemic is shrinking. So the goal of this analysis is that the study's authors took the number of new cases observed in Wuhan each day. They fed it into a software package that had been developed years before the pandemic started to produce these RT estimates. They got an answer out the other end of that analysis, and then they were able to plot their RT estimates on this graph with annotations of the level of intervention that was in place in Wuhan at different points in calendar time. And so the goal of this analysis is basically to try to figure out what level of intervention was sufficient to drive that RT value below 1, meaning that the epidemic had started to recede. But I want to draw your attention to some critical details about this analysis that can affect our public health interpretation of the results. So the first thing I want to point out is the kind of suspiciously narrow credible intervals, given how much uncertainty there was at this very early point in the pandemic back in April 2020 about basic biological aspects of the disease and the ascertainment rate of cases in the source epidemic. And this is important because hypothetically, if the width of the credible intervals were wider, then you can see that there's a much wider period of time at which the reproductive number value might actually have fallen below 1. And in this example, if that interval is wide enough, then there could be 2 different levels of intervention that actually caused the epidemic to start receding, and we can't be sure which one was necessary or sufficient to achieve the desired outcome. And then the other important idea that I think this figure illustrates really nicely is that if we want to use RT to assess the effectiveness of public health interventions, we really need to be sure that when we estimate these quantities, the timing of RT falling below 1 is accurately oriented to the calendar date. And so if you look at the x-axis in this plot, you can see that the timescale is pretty short. This is only covering a few months. Each of the intervention periods are only a week or 2. And so if we're off by even a few days in either direction on the x-axis, then it can qualitatively change our interpretation of the effect of different interventions. And so this is a problem because we know as epidemiologists that public health data tend to be quite messy, especially as they're observed in real time during a novel outbreak situation where data systems are often being built on the fly. And it is inevitably true in public health data that there are going to be lags to reporting. We often see these day-of-week effects where the number of reports fluctuates depending on whether it's a workday or a weekend. And furthermore, there are biological delays, such as the delay between the moment a person is infected and the moment that we can observe their infection because they became symptomatic or were tested or ended up in a hospital. And so in order to estimate RT accurately and make sure that it's accurately oriented in time, we really need to use a model that has thought through these problems in advance. And so this is an example of one of the kinds of tools that was built on the fly during the pandemic to do this kind of data pre-processing well. So what you're seeing here is that the gray bars represent the raw observed counts in an epidemiological time series. And you can see in those gray bars there are all of these issues, right? There are these day-of-week reporting effects. We know that the observations at the end of the time series, which is usually the most recent events that public health decision makers care most about, are still in the process of being fully observed. And we also know that if we're trying to estimate transmission now, we have to adjust for those lags between the moment that a transmission event occurs and the moment that we can actually observe that infection. And so this modeling analysis is designed to take the raw data, adjust for all of those problems, and infer or estimate the underlying unobserved time series of new transmission events, which is shown in the little green line. And you can see that it's smoother and it's shifted on the time axis in a way that more accurately represents the current trends in transmission. So this is an example of a package that we would want to use to do this analysis well, and CDC is actively supporting the development of this kind of work, including through maintaining a large team of modeling analysts at CFA that are building these kinds of tools, as well as supporting community development of existing tools that were built during the pandemic to do this kind of work well. And this ties back into that idea that early in the COVID-19 response, the analytic tools that we had in place were not necessarily pre-positioned to do this kind of analysis well. So as the pandemic started, a lot of modelers realized that there was a lot of work that we needed to do on the fly to make sure that we had clean pipelines to feed the data through and do this kind of adjustment so that we could pull answers out of the end each day that we trusted and knew were accurate. During the pandemic, the methods available to do this kind of work improved dramatically, but because they were built on the fly, some of the design choices maybe would have been made differently with the benefit of hindsight. And so this is really the driving purpose of CFA. So we are here to try to think through the lessons learned during the pandemic and build the kind of computational and analytic infrastructure that we would need to do these kinds of analyses well and quickly in the event of another novel outbreak. And furthermore, building this kind of infrastructure will enhance our ability to track endemic seasonal pathogens and diseases, including influenza, COVID-19, and RSV. And so we see this as a long-term, sustained initiative that is going to take years to fully realize. But our vision is that eventually we'll have a well-tested, professionalized set of tools in place that we can use here at CDC and that we can share with our public health partners at the state and local level for analysis in-house.